Good evening, ladies and gentlemen. My name's Barbara Anderson. It's a great pleasure to be here tonight to introduce the Fulbright scholar, Prajwal Ciryam. Prajwal was born in India but grew up in North Carolina, and he got his biological sciences degree from the medical faculty at Northwestern University. But he is currently at the University of Cambridge in his role as a Fulbright scholar, and he's doing research into protein misfolding. Now, please don't ask me to explain to you what that's about, because I haven't the slightest idea. But it is a problem that underlies a lot of diseases, including Alzheimer's, Huntington's, diabetes, and many others. And he is also very interested in curable eye diseases like cataract surgery and that sort of thing. And I'm hoping he might tell you a little bit more about that during the course of this evening. There will be time for you to ask questions afterwards, and we'll have some handheld mics ready for you. So now over to you, Prajwal. Thank you.
Well, thank you very much, Barbara, for the introduction, and thanks to all of you for being here. You're very fortunate that I won't be talking about protein misfolding. I think I'll be talking about something a lot more interesting. All right. The tragedy of easy problems. This is a phrase, a concept that's been running through my mind for really the last few years. I started thinking about it when I was in India and Ghana, seeing surgeons doing really extraordinary work, restoring vision to people who'd been blind for months and years, and doing so for as little as $5, with a surgery that took just 5 minutes. I remember volunteering in 2005 in Chennai, India, in southern India. We, the volunteers, optometrists, nurses, went to the Anna Iliam nursing home right in the center of Chennai, met with and screened extraordinarily poor patients who hadn't had any kind of health care in quite a long time, who hadn't had the opportunity to be cared for, which is a lot of what people are looking for in healthcare, but also hadn't had the opportunity to have really treatable diseases taken care of. We screened patients where you could basically see across the room that they had cataracts and that they'd been blind for quite a long time, and were able to then get them to a hospital where they could be treated. And I remember these 3 elderly women who were so nervous but so excited getting to the hospital, this opportunity to see again. They had so little in their lives, but this one gift to be able to see again was extraordinary to them. And when they came out, the kind of hope and opportunity they felt for the years they had left on this earth, years that would be enriched by the gift of sight. Now, this isn't a tragedy. This is a story of tremendous hope. The tragedy of easy problems is that this problem, cataracts, and many other problems, including vaccines, vaccinations, diarrheal diseases, a long list of others, a few of which we'll touch on. The tragedy is that these solvable, easy problems go unsolved, so that millions of people in the world, 20 million people, are blind from cataracts. Hundreds of thousands of people die from diseases that we know how to cure, that we can afford to cure, but we have failed to cure. Now, I'm not saying that it's easy to deploy huge amounts of resources all over the world. The implementation of development solutions is never easy. But what's easy about the problems that I hope we'll discuss tonight is that we know how to solve them. So we have a technical solution. With cataracts, we have a very effective surgery. We have a financial solution. We can make, with cataracts, we can build hospitals that are sustainable, where all of the revenue that's coming in is enough to take care of a lot of patients who are very poor. And we have logistic solutions to reach the patients who need to be reached. All of those pieces are in place, have been demonstrated to work in the developing world, but just haven't gotten everywhere that they ought to get. That's the tragedy, that we haven't done what we know how to do. Now, there are a lot of easy problems, and they have solutions. They're economically feasible, technically effective, logistically scalable. So I want to elaborate a little bit more on these three ideas. Now, economically feasible. It's fine if we know how to cure disease. We can treat AIDS extraordinarily well in the developed world if you have enough money to do so. But it's much more difficult in the developing world, and we haven't figured it out because it costs quite a lot. There are a lot of diseases that don't cost a lot to treat. Technically effective, not everything, we don't know how to treat everything. Malaria is an example of a disease where we have some working solutions, but we really need more technology development before we have the really effective solutions that can be brought to scale. And then finally, any solution that we're going to implement in the developing world, the logistics have to be scalable. We have to make sure that we can reach not just 10 people or 20 people, but 10,000 and 20,000 and 50,000. Those are the effective solutions. Those are the that's the low-hanging fruit of global health. But there are a lot of things that fit all three of these categories. I mentioned three of them already, and we'll talk about a few more. Now, I want to start with cataract blindness because it's something that I have a little bit of experience working on. So I'd like to give you a little bit of background about it and use it as an example to extend this idea of the tragedy of easy problems and how we can fix it. There are 40 million people in the world who are blind, 20 million from cataracts. Now, cataract surgery is basically as old as recorded history. So for thousands of years, people have recognized cataract blindness as a problem, and they have tried to treat it in one way or another, not always effectively. The ancient Egyptians and the ancient Indians would basically bash a person's eye when the person had cataracts so that the lens, and now cataracts are an opacification of the lens. The lens becomes completely opaque and hard, and so the light can't get through. So they'd bash the eye so that the lens would break up. And as it floated to the side of the eye, light could get through. You might not be able to see very well. You might end up with some major brain damage, but it was the best they could do 4,000 years ago. We've made some improvements, as it turns out, which is very exciting. In the 1700s, some people in Paris had the bright idea to just remove the cataract by making an incision and taking it out. This still, of course, leaves you with the problem that there's nothing to replace the lens, which is supposedly focusing your vision. And it wasn't until the 20th century that we were able to develop plastic lenses that could then be inserted into the eye to replace the lens that was removed. And this was an extraordinary development because it meant that people who had previously had to wear these thick Coke bottle glasses that had really become, in many parts of the world, a symbol of infirmity, a symbol of an inability to take care of oneself, a symbol of weakness, that those were gone, and lenses that actually worked could be used. Now, you might think, removing a lens from the eye, replacing it with a small plastic lens, sounds all very expensive. But these lenses can cost as little as a couple of dollars. And these surgeries can be done so quickly. I've seen a surgeon do the surgery in 4 minutes. Make a cut, remove the lens, replace it with a new lens. 4 minutes. Sometimes it's done even faster. When the surgery can be done that quickly, the cost per surgery of the surgeon's time, of the overhead, becomes very, very low. So that study after study shows that in the developing world, we can bring this cost down to $10 or $15, almost nothing to restore sight, such that cataracts are actually considered the best bang for your buck, the best value for money of any surgical intervention that one can do in the developing world. So despite all these great things I just told you, the backlog of these surgeries is growing, which is extremely alarming to me. And the tough part is getting to the patients. Now, there is an extraordinary story of figuring out how to get to the patients and get them this fast, cheap, and highly successful surgery. So we talked about this a little bit already. So the 4 big things: high throughput, thousands of free surgeries can be performed, high quality, the small incision cataract surgery with an intraocular lens. That's a lot of words, but basically it's just making a small cut, cutting that lens into pieces, bringing it out, replacing it with a new lens. Can be done in a few minutes. Price is really cheap. And the patients who can afford surgery subsidize patients who can't. Now, this is the Arasan Eye Hospital in South India. And it's not the first of these hospitals, but it's one where I've spent quite a bit of time. It was actually my first exposure to cataracts. Before I visited this hospital in 2005, I thought cataracts were waterfalls. But I've since learned better. And here in this picture actually is sort of an extraordinary emblem of what we need more of in the developing world. So Artisan Eye Hospital has 6 surgeons. They do 10,000 free surgeries a year. And they covered with the cost from about 2,000 paying patients. Most of the folks you see in this picture, though, aren't from Artisan. They aren't from South India. They aren't Indian. They're actually Ghanaian. And they were visiting Artisan from Ghana to learn. They're physicians and nurses who were there to learn how the system worked and how they could take it back to Ghana and implement it there, which is the kind of collaboration across borders between developing countries that have similar problems that I think is very exciting. And this gentleman here, Dr. Michael Jesse, became a partner with us for the next few years after that. Now, this model started back in the 70s. This gentleman is one of the most important people in thinking about eye care in the developing world. Govindappa Venkataswamy started the Arvind Eye Hospital. And his goal was, let's do for eye care what McDonald's did for hamburgers. Let's get eye care to millions of people. Let's do it at a low cost, and let's make it efficient. He implemented an assembly line approach in his hospitals so that when patients came in, each healthcare worker that they dealt with had a specific task, and the patients were moved along the assembly line from intake to the operating theater, into the surgery, post-op care, and out, so that the amount of time that the patient spent going through this process was as small as possible, and the ophthalmologist's job was kept to doing surgeries. What he got were extraordinarily good outcomes. These surgeries can be over 90% effective, and he got them fast and cheap. Now, this idea emerged from really an ether of volunteer spirit in southern India at the time, and I think it's important to remember that these great ideas that emerge organically in the developing world do often come from some kind of sustained tradition. So ophthalmologists in India were running eye camps where they would rent out a temple or a school or whatnot and advertise broadly, get folks to come in and screen thousands of people in a day with a few dozen surgeons, and then perform cataract surgeries right on the spot. The big change here was to recognize that doing a surgery in a school is not going to get you as good outcomes as doing a surgery in a hospital. And therefore, you focus on making the hospital very efficient, and you spend a lot of time and money reaching out to villages, to communities, and bringing patients back in. That's what Arvind did, that's what Artisan, where I visited, did, and they were able to bring in, on the days they were bringing in new patients, 40 or 50 cataract cases, and to get through them in a few hours. Arvind even more. Arvind is now this massive hospital that sees hundreds of thousands of patients a year and has done millions of cataract surgeries. This is really the granddaddy of the example. But the point being, this stuff really works, and it's worked for a long time, and everyone pretty much agrees on that. Now, cataracts aren't the only easy problem, as I've said. We've got a great legacy of dealing with easy problems. This is something you'll never see again. This is a child with smallpox, a very bad case of smallpox. But of course, smallpox has been eradicated because of a global effort to take something that we knew how to do, which was to deliver vaccines very efficiently, very cheaply, and make sure we did it at a global scale. Smallpox gives us the template to be able to eradicate lots of other diseases for which we have vaccines. We've actually only eradicated one other disease, though. How many people have heard of rinderpest? Never heard of it? We've got at least one person who's heard of it. So rinderpest was one of the most debilitating diseases for farmers. It's a veterinary disease that affected cattle. 1 in 4 cattle that got rinderpest died. Last October, scientists at the UN announced that rinderpest was gone. It was eradicated because of a large-scale vaccination program. And it's the only other disease besides smallpox that has been eradicated. Although polio, with the polio vaccine, is on its way. In the next few years, polio should be eradicated. And guinea worm, which doesn't have a vaccine, the Carter Foundation has been very busy trying to eradicate it through a really strong educational campaign. They've gone country by country getting rid of this disease. And why guinea worm is exciting is that, okay, so polio just demonstrates that we can use smallpox's legacy of building infrastructure for vaccines and get vaccines out there. This guinea worm story, and guinea worm is an awful disease that you get. You drink water, the worm grows inside you, it can become 3 feet long. The only way to cure the disease after you get it is to pull the worm out through your foot, which is extraordinarily painful and not always effective, and there are all sorts of secondary infections that occur with it. But the Carter Center, just by getting people to drink clean water and be more and improve community hygiene, has brought the number of cases down to from hundreds of thousands to just a couple thousand cases that were reported last year. And their educational campaign gives us a template for other campaigns. Now, and this is someone with polio, obviously. Now, we need to seize the opportunities that we haven't seized yet. So polio and guinea worm are a great example of where we are combating this tragedy of easy problems. Diarrheal disease seems to me, despite the progress we've made, an example where we haven't done nearly enough. Now, a couple million people die every year from diarrheal diseases, usually caused by infection, but sometimes from other sources. And that includes about half of those people are children under the age of 5. Now, this is a picture of rotavirus, which causes about 40% of hospitalization level cases of diarrhea. We have a vaccine for rotavirus. Since we know how to get rid of diseases with where we have a good vaccine, we should be able to get rid of rotavirus. We know how to treat diarrhea after someone gets it. Oral rehydration therapy with zinc, basically giving people water, salts, and sugar and throwing in a little zinc, is extremely effective for lots and lots of cases. But only 40% of children who get diarrhea get oral rehydration therapy in the developing world. That is a stunningly low example for a therapy that costs 10 cents per liter. Now, not everything. As I mentioned before, malaria is a case where the problem is technically still a little bit intractable. The drugs stop working because the pathogen evolves. We can't quite get everything. The mosquito nets are great, but they aren't perfect. But we might be able to innovate this into an easy problem sooner than we think. There is a really exciting trial that everyone who's interested in the 800,000 people who die from malaria every year and the 225 million cases that we have should be following. It's the first phase 3 trial of a malaria vaccine. The vaccine could be on the market as soon as next year. And that is extraordinarily exciting because it could put malaria on the list of diseases that we can eradicate. The safer bet, perhaps, is taking care of the tremendous shortage that we have right now in the actual malaria drug. We can't make enough of it. There's a professor at Berkeley who is using yeast to produce the drug instead of standard synthetic chemistry. And he thinks, and has shown some good evidence, that he can bring the price of the drug down from $2.40 a dose to 25 cents a dose, which, again, means that the access to that drug in the developing world could increase tremendously. So sometimes a problem isn't easy yet, but as the technology moves forward, we get a solution that is economically feasible, technically tractable, and scalable. Now, why don't we address these easy problems? If it's so clear that we should get kids vaccines, if it's so clear that we should provide oral rehydration therapy, why is it that we haven't done so? And I've scratched my head over this problem for quite a while, and I can think of 2 big reasons, and there are probably a whole host of other ones, but 2 big reasons why we don't prioritize these diseases as much as we should. There's a perception problem, and then there's the medical mission problem. The perception problem is just that it's boring to talk about things that we already know how to do. It's not the way that our global discourse is generally set up. It's not the way the news cycle is set up. So everyone knows that there's been a polio vaccine for decades. That's old news. And so it's not going to get it's not going to get as much attention or as much funding as it should because it's already been there. There was a great New York Times article a couple of years ago asking whether the fact that we were increasing funding for AIDS in the developing world was preventing us from funding diarrheal diseases. And the director of UNICEF, or the director of health for UNICEF, made the point then that absolutely donors were focusing on the new and exciting diseases and were ignoring the diseases that it just seemed like, why would we have to worry about that? We already know what we're doing. I'm sure we'll carry on and it'll improve. Forgetting that the implementation is as important as the idea, as important as the concept, as important as the breakthrough. So there's a perception problem that in the media, amongst the donor community, it's easy to forget about the problems we already know how to solve, and that's why they remain on the table. Now, the mission problem, I think, is a little bit, I actually think, is a little bit more problematic because it's hard to figure out how we change the structure that builds it. Now, at least in my experience in medical school in the United States, the way that physicians, the way that healthcare workers, the way that students engage with global health tends to take the medical missionary format. So this is sort of spending a few days or a few weeks or a few months going to another place, doing short-term direct care, and hoping that that's going to make an impact in the community, feeling pretty good about directly helping some people who really need it, but then not leaving a strong infrastructure behind. This is obviously a problem, especially now that everyone likes to talk about sustainability. These programs tend not to be very sustainable. But they're easy to put together. They're easy to do, and they are very personally rewarding. It's not as rewarding to sit in front of an Excel spreadsheet and try to sort out the finances of a clinic because the clinic doesn't have enough accounting staff to be able to do that on their own, or to put two people in the developing world in touch with each other so they can work together on a project. That's kind of boring. Going in and doing some surgeries, if you're a surgeon, that's what you like to do. And it's a lot of fun, and you feel like you're making an impact, and it's really great, but it means that we ignore the easy problems which tend to need a scalable solution. You can't bring these medical missions to scale because there's only a limited amount of time and a limited amount of resources amongst developed world physicians and medical students and whatnot. And really what we need to be doing is figuring out how these folks who are incredibly talented and incredibly giving and have wonderful hearts can use their resources to best serve these communities they want to help serve. Now, there's a guy, and sort of a technology commentator named Clay Shirky. I don't know if anyone's heard of Clay Shirky. He talks about a cognitive surplus in the developed world, that we have all this extra free time and energy, and mostly in the last 50 years we've been spending it watching TV, but now we're getting interested in doing some other things with this free time and energy, and the improvements of communication make us able to do that. So the cognitive surplus is that we can take this free time and we can spend it on helping folks who don't have that kind of free time, helping in the medical setting, helping people who can't worry about long-term solutions because their hospital has a long line of people coming in with malaria, and they've got to treat that right now, and they can't think about how I build my community's healthcare infrastructure 15 years into the future. That's where we can help. They don't have time to say, well, let me look carefully over the course of history and the literature on what people are doing everywhere else in the world, because they've got to take care of the problems they face now, the funding, the limited funding they have now to be able to help the people they see in their communities. That's where we can step in and say, well, we have the cognitive surplus to make a survey of the great and exciting things that are going on, the easy problems that we know how to solve, and connect the people who've solved those problems, connect people like Govinda Venkataswamy with the folks in communities in Ghana, in sub-Saharan Africa in general, with those solutions and with the relationships that help them bring those solutions to fruition. What we need is not the medical mission, but the kind of medical vision that connects people to real solutions, solutions that address these terrible, easy problems. Now, I'm very careful in saying this because some people got really mad at me when I said it in a presentation in my medical school in Chicago. And it's because it might sound like I'm saying that workers are, these healthcare workers who are going to the developing world are really selfish and doing things just out of their own desires. And I guess I am saying that, but I'm not saying that's the worst thing in the world. When we're trying to figure out what to do, how to make development projects work, we need everybody to feel invested. So we need communities to feel, the local communities to feel really invested and to be able to set agendas and priorities. But we need the folks who are going halfway across the world to try to help them to also feel invested and connected and like they're making a difference. And then we need opportunity. So let me give you an example from my own personal example. I was in Chicago with a friend of mine who's a community organizer. And he said, you development folks are all the same. You go into these communities, you don't ask anybody anything, and you just do what you think you should do. And this doesn't make any sense. You want to work on cataracts? Great. You should go into the community, take a survey, and maybe you'll be working on toilets instead, because that's what they need. And I think that this is a reasonable point, that we need to weight the community's desires. But there's a reason why development people don't always do that, because you might have a set of people who have a particular skill set. So a bunch of ophthalmologists probably are not best used in helping people to work out water sanitation. And so the development workers who are going in, we need to consider their desires as well. And then there's opportunity. The reason that I got involved in cataracts is not because I had any special knowledge or I had an understanding of a special need for cataract surgeries over every other kind of medical intervention in West Africa. That was clearly not the case. The reason I got involved was I happened to be, along with a few of my friends, in the right place in the right time, making the right connections to link up, to help mediate a relationship between surgeons in Ghana and surgeons in India, and to try to foster and encourage those surgeons in Ghana to build sustainable clinics after the model that existed in southern India. That was an opportunity that was luck. And it makes no sense, in the face of luck that gives you a strategic advantage to really do something powerful, to say, well, I'm going to go and do the survey and see exactly what they want, and even if I don't have the connections in that, I will do that. That doesn't make a lot of sense to me. I think you got to bring all these three things together. It's really a triangle of incentives that, working together, you can figure out what it is that you actually want to do and what it is that you can do the best. And so I encourage folks in global health to keep using their passion, but just to find the right conduit for it. Now, it's really easy for me to get up here and say these things, and it was easier for me to do it a year ago because things were going very well in our project. But as I told Barbara before this talk started, my work has failed. Cataract International is the organization through which a few friends and I started to work on trying to connect these Indian physicians with West African physicians and try to get the funding and the technical support to build high-volume, low-cost, sustainable cataract surgical clinics, first in Ghana and then West Africa in general. We spent years working on this project, worked with a physician in Ghana, Dr. Michael Jesse, who's incredible, and who, any good things that come out of it, credit to him. Any bad things fall to us. To start a pilot clinic, which started about a year ago, was going very well, but funding was tough to get. Coordination was tough to do internationally. It's hard to manage a volunteer corps that was then interfacing with full-time staff on the ground in a way that made a lot of sense. And we just, quite simply, for all of the reasons that development projects usually fail, something like 50% of water projects fail according to the nonprofit water.org, and all the reasons small businesses usually fail, we failed. The clinic is still there, it's going strong, organized a little bit differently than it was otherwise, but our ability to take that pilot and bring it to scale in the way we wanted couldn't happen in that place and in that time. Now, what we learned was a lot about management and a lot about the necessity of getting funding right at the beginning, seed capital, to be able to run an organization. But that's a little boring. Everyone knows those lessons, but everyone has to learn them for themselves. What I think is very important that we learned was that with the understanding that almost everything that you do that's worth doing is probably going to fail, you need to know how to succeed well, but also how to fail well. And this is very important in targeting these easy problems, and it's very important for development in general, because since so much fails, we have to get the most out of every stage so that we can set up to try to solve the easy problem the next time, because the implementation is never easy. The implementation is always hard. It's just the concept that's easy. And so I still think building large-scale cataract hospitals in the developing world in West Africa is a great thing to do and needs to be done, and I would love to be involved in doing it in the future, but our first shot at it didn't quite work out. So we thought, okay, how do we get the most out of every stage? How do we fail well? And you need to have well-defined stages. So can we think of a way to have a more process-oriented approach, to identify these new great ideas? Because really what we were doing here was stumbling on a really effective idea and trying to bring it to scale. Can we do that in a more systematic way? And so that we really can get the most out of every stage, like we're trying to. And this is a new project that hasn't even started yet. All it has is a logo and one other person. But we're very excited about it. It's Layla Wilmers and I. Layla Wilmers has worked in development and is a friend of mine in Cambridge. And it's a development research to action group. The idea is to systematize this sort of happenstance approach by which a few other friends and I had stumbled on cataracts to get the most out of every stage. It's process-oriented because it works in 3 phases. So the first phase, we think broadly. We spend several months looking into every sort of global health problem we can think of, things that are working, things that aren't working, identify what's really exciting, and where there are opportunities to take local solutions and make them global solutions, and find the connections to do that. Then you pick one of those problems that's really exciting. So at this stage, you say, I'm only going to go on to the next stage if I succeeded at this stage. What did I want? I wanted to get this information about lots of ideas and pick one. All the other ideas I had, I want to write about them along the way, and the ideas we don't use, give them to the public domain, so that whatever we've already spent time doing, someone else doesn't have to do. So that kind of open source approach, I think, is very important. That's a way to fail well, so that if all we do is spend a few months in the first cycle thinking about things, those thoughts are used. Now let's say we go to the next stage where we realize this idea specifically. We expand on it. We build a business plan. We make the connections in local communities. We find the right local community and the right local partners. We get the initial seed capital. And at the end of that stage, we want to have everything set up to be able to move forward into sort of a much larger project. And at that stage, you build the details. So even if at the end of that stage you say, well, we don't have the money to do this, or we don't have the resources to do it, we will have the plan to do it, which again could go into the public domain so someone else can pick it up. Because it's so important that wherever one leaves off, someone else picks it up. And then finally, yield results sustainably. So build sustainable, economically feasible, scalable projects that then get spun off. And this is all about the cycle. So spin off these new pilot programs with a few of the people who participated into an independent organization and start the cycle over again, so that we can identify as many of these new, exciting, maybe not new, maybe very old, exciting programs that have been demonstrated to work, and try to find ways to take them to the next level, using the fact that the one advantage that people in the developed world have sitting here is that they can be these boundary spanners that connect communities, disparate communities. We aren't going to have the most expert local knowledge. We aren't going to be the best ones to be providing direct care. What we are going to be useful for is to provide those background resources that enable folks to do more than they could have otherwise. And we're very excited about this. Like I said, we haven't done anything at it yet, but it's what I've learned from the failures I've had and the general concept of the easy problem. We think this is the platform to target these easy problems, the ones that haven't been targeted yet, and really start to make an impact in the ways we already know how. It's great. There are people out there doing incredible research, and they're going to make more and more problems easy to solve. But what we'd like to do, and what I think the development community needs to do more, is to take that long list of problems that we already know how to solve and go about the business of solving it. So thank you very much for your time, and I'm very happy to take questions. Got a lot of people to thank here, but you can read that. Thank you. Please, sir.
Two questions actually. The first is to ask about the smallpox eradication and how that overcame the problems you've described. And the second is to say that if you have a global problem, don't you need a global sort of administrative structure, and where does the World Health Organization fit in?
Two excellent questions. So in case people didn't hear them clearly, the first question is to go back to the smallpox example, which was, a great success. How did it overcome all these problems? And the second was whether global problems need global solutions and where the World Health Organization comes in. The smallpox eradication wasn't easy at first. Much of the world community did not sign on early, and it took advocates pushing for quite a while to get the kind of global participation that was necessary. And really the only way to answer how that worked is to really reflect on your second question, which is, what is the role of organizations like the World Health Organization, organizations like UNICEF and UN? Where does global governance come in? Because it is at the level of the politics of global governance that you can coordinate these efforts. And I think that where those organizations come in, and where they came in with smallpox, was to be able to provide the kind of funding that's necessary to deploy these programs, to set the priorities that are necessary, and in some cases to build the structure and to get the local legitimacy. That said, there is this big debate in the development community, and I like to think of it as a crosstown debate in New York between Jeffrey Sachs at Columbia and Bill Easterly at NYU, where Sachs is very committed to global institutions and big programs, and Easterly is very focused on helping people to innovate from the bottom up. And honestly, the answer to this is like the answers to everything. You need a combination. The World Health Organization, as it sets these big priorities, needs to be figuring out how to empower local ideas. So you can say, we want to solve smallpox, and here are some great ideas of how it's been, or we want to solve, no, we don't want to solve smallpox anymore, but we want to solve, we want to end polio soon. And here's how it's been very effective so far, and here's what we can fund. But some ideas need to be tailored to your local communities, and we encourage you to take the knowledge that we have that we can help to provide, and then to tailor these programs for your communities. I think the Gates Foundation does a remarkable job of towing the line between setting priorities and drawing on local expertise to tailor programs. But that kind of implementation is always a very difficult dance, which is why so many things fail, and so many things will always fail. But I think there's a role both for the top and the bottom. I hope that answers your question.
One thing I don't know if you touched on, or if in the first few minutes before I got here, but I don't think you addressed any of the problems that are pretty common in global health and development when there are, well, I guess they're not all that common, but there are sufficient resources, there is sufficient political will, and yet we still can't solve them. So they're even easier than some of the ones that you've addressed. And before coming here, I was working for an organization that was trying to sort of systematize the study of those sorts of problems and then disseminate knowledge on those sorts of things. So I'm wondering, I can tell you sort of our organizational ideology as to what the problem is, and the organization sort of stemmed out of the 3x5 campaign.
Sure.
You know, we had everything we needed. Why couldn't we do this? So I'm wondering what your take on those issues really is.
So I think that there is sort of the fundamental problem that there are always little details that stop things. But to be less pat than that, when we have the resources, when we know what to do, when there is the political will, it is still difficult to find the right partners sometimes. It's still difficult to decide whether a system that's worked in one place is going to work in another. Sometimes we're very, very sure of that, and sometimes we're less sure. And I think that part of the problem can be that difference between being 100% sure that something works everywhere and being maybe 60% sure. I would be very interested to hear what your thoughts on this are, but a great study that everyone should look at, and is in the notes that got passed out, and let me make sure that I get the names of the people who did this correctly, which took it from the other angle, which is when things do work. How well do they work? It came from I believe from the Center for Global Development, and they basically took 20 cases of really effective globally scaled programs and asked what were in common amongst these programs. And it was largely the sorts of things that we talked about, which was that if you do, and on top of that, political will. So if you've got the government actors, you've got the money in place, you have the right system, you have the technical solution, and it's the kind of infrastructure that can be scaled, then that's what you need to make things work. I think it's a much harder question that perhaps you're better able to answer than I am, as to when you have all of those things, what are the details and what are the catches that make things not work? I can only tell you from my experience, because I think I sort of sat in that situation where we thought we had all of those things worked out, and it still didn't work. And I think it does come down to management and human resources and details of funding. But
yes, thanks for a very interesting talk. I was just wondering, because in this country we have the overseas development aid, and you know, ever so many millions goes to India and the third world. I was just wondering where you get your funding from.
So I'll say that our biggest problem was that we were never able to get quite enough funding to have the kind of agency to make real differences. We were getting funding from university grants, from the university I was affiliated with before. The challenge with the kinds of overseas aid that you mentioned for new organizations is that you need quite a track record before you really do qualify. And I think that makes a lot of sense because government funding, you don't want it to go to a bunch of people who don't know what they're doing or who haven't demonstrated that they know what they're doing. So the usual progression for new organizations is to get private donors, to tap connections they have, to try to get a pilot going, and then to try to get big grants like that. We never quite got to the stage where we could nab those big grants. But we're hoping with the next project we might be able to do that. The second project I mentioned is not funded at all. It is on the drawing board, and we're trying to recruit the team right now. But it's an idea that I wanted to end the talk with because it really is the end product so far of my thinking on this, and it is a way for me to sort of reflect with you on the challenges that we've faced in doing development work and some of the ways that we want to get around it in a small-scale entrepreneurial sort of way as opposed to sort of a grand governmental level.
Do you see the tragedy of easy problems arising in areas outside of the field of health, or alternatively arising in the field of health but in the developed world in the same case?
Absolutely. So I focused on health because it's the only area in which I'm even marginally qualified to say anything. Even that is dubious, perhaps. But certainly, there are all sorts of solutions which I feel a little bit put out to try to be sure that they're really easy problems in this way. So I'm not going to give a list, but I think this is a generic phenomenon that the way that we tend to engage with global problems is such that the things we already know how to solve get left out. In the developed world, there certainly are examples. I think you look at you look on a more local scale. I think so. Let's take the United States, which I know better than Britain. The political problem of getting health insurance to everyone is not an easy problem. That's a complicated problem. But if you go on a city level, if you go on a county level, the delivery of care, there are clear things that we could do to be able to deliver care more efficiently that don't happen. And I think that we can ask the same sorts of questions. Why aren't they happening? Especially in that context where we know they're economically feasible.
Yeah, I worked with an organization called Médecins Sans Frontières in Nepal, where we introduced for us what was quite an innovative project involving surgical camp. One of my concerns about the surgical camp, and I guess a concern that I would have with the type of projects which you're thinking of, is that it felt quite dehumanizing in the end. That it had this aspect of having an assembly line. So that it's generally just a concern of mine.
Sure.
That so that it comes with these problems which are easy to solve, and therefore we introduce a very technological solution, which in the end sort of fails to ignores actually that you're dealing with a patient in front of you. So I think that's a concern of mine. And then the other concern, just a point that you made when you were talking about actually the things that we as perhaps medics from the developed world can bring to other countries around the world, which is rather that perhaps we can bring immediate care, we can provide the immediate care, and actually the people who are better placed to introduce the system of healthcare for the sustainable system are the people who actually work there. In fact, it's not, maybe we're in the wrong place to create the system, and it's actually the people who are there who are better placed for that, and it's better that we provide that immediate care to give space to people to start thinking long term.
So, yeah, no, there are two very interesting points, and let me, can you say the first one again, because I started thinking about the second one, and
yeah, the first one was just in relation to...
the dehumanizing of, yeah, right, and so I think that, so I struggled with this question when I first saw the setup of these clinics, right? So when you have a clinic like this, patients don't have private rooms, they, where they rest or in sort of large groups together. They don't have the same kind of standard of privacy, of personal attention from physicians that we're used to getting here. But then I ask myself, that whether it is possible both to meet the need given the current resources of physicians in these countries. For example, in Ghana, there are 52 ophthalmologists, and there are 10,000 new cases of cataracts every year that need to be taken care of, plus a backlog of something like there are 10,000 new cases and a backlog of a few 100,000, such that they need to do 50,000 a year. We only do 10,000. So my concern is, yes, we want to have healthcare systems in all of these countries that treat patients as well as possible, but on sort of the healthcare variant of Maslow's hierarchy of needs, helping these people to get the care they need now and in a way that the system can perpetuate until resources catch up is more important in my judgment than being able to provide the exact standard of care that exists in the developed world. I think that's a judgment call, and I think that there are legitimate value systems that would lead you to either position. But my judgment is that if we can get the care, then great. Now, your second point is very interesting, whether the physicians who are on the ground are really better placed to plan this infrastructure than other people are, and whether we ought to be doing sort of direct care. And I think you said you work for MSF, right? And MSF is a great example of an organization that absolutely should be doing direct care because it's largely working in situations that are disastrous, where direct care is the most important thing to be done. Now, in, say, a country like Ghana that's a democracy that has a national health care system, which America doesn't have, and has not a lot of physicians, but some physicians, and has some stability, has a lot of stability, is it best for physicians from the developed world to go and be providing direct care? I think it's stifling. I think it decreases the incentive to build local structures, and it is, to some extent, not the best use of the time of those physicians, because I think there's a difference between the kind of care, this goes back to your first point really, the kind of care that a local physician can provide and one from the developed world can provide. And I would still hold that the developed world physicians have an ability to connect people across borders and to bring ideas together across borders that is less accessible to folks in really resource-limited developing world settings. Now, this doesn't mean that we should go from the developed world and start dictating to people how to run their hospitals. It does mean that we should think about how we structure those partnerships so that we can bring the most to the table that we can bring. And I think we can do more than bringing direct care, although in situations like MSF, that's the best thing to bring. Well, if those are all the questions, then thank you very much for the fantastic questions, which were better than my talk, and I really enjoyed it.